Next speaker, Dr. Tae Cho from the Westmead Public Hospital, Australia. He is a vascular surgery to present us a second interesting case, a type 2 endoleak.
Thank you. Thank you, Medtronic, for inviting us to come all the way to Bangkok to present today. I'm a bit nervous because currently Australia is playing in the Women's World Cup, and obviously we won France today, so we're in the semi-finals now. So here we go. So even though I work in Australia, I have a strong relationship with Asia. I even trained at Singapore General Hospital during my junior years. And I went to Oxford to get some open experience. And one of my senior colleagues called Jack Collins is infamous in England in 2001 because he published this paper in the British Surgery Journal and were ridiculed. Now, the thing is, the paradigm has shifted, and since that time, we do most of our aortic surgery with endoluminal repair. But some of the lessons that was mentioned in this paper holds true. We still need reintervention. We don't have or haven't eliminated the risk of rupture completely with the presence of endoleak. And I think it's important that we surveillance these patients for life, as Professor has mentioned, and treat accordingly. So the patient I'm presenting today is a guy called JP. So I first treated him in 2012. At that time, he was 77 years old and relatively well. But he was against open surgery and he wanted endoluminal repair. So we repaired his aneurysm the month later using a standard, I think it's the original Endurant 1 graft using 3 pieces, and it was pretty standard. So this is his completion angiography, and you can see that he had a patent IMA even at the time of the operation. And where we're from, we tend not to preemptively treat any type 2 endoleaks, and we don't tend to treat them post-operatively, even unless there's sac expansion. So back at home, we do most of our surveillance with ultrasound rather than CT. And then this is his post-operative CT at 4 weeks, and he's had a centimeter of sac regression already, but you can see that his IMA was still patent. So we surveillance these guys every year for the rest of their life, or until the surgeon dies. Then we surveillance him every year, and there was no problem at all. So you can see the sac remained pretty good. This is 6 months, and his IMA actually had occluded by then. So I was feeling very, very confident. Then in 2016, then I noticed that his sac was a little bit larger than what we measured 12 months ago. But of course, you know, with ultrasound, there's variation with sonographers, and there is plus or minus. So I thought we should just sit tight. Then he came back another 12 months later, and the sac seems to be getting slightly larger still. But there was no obvious evidence of endoleak on ultrasound. Then, like normally with our patients, he got lost to follow-up, and he hadn't seen me for some time. Then COVID came, then they never turned up to follow-up. Then in 2021, he basically presented to one of our hospital with non-specific abdominal pain. And then we started to investigate him then. Then unfortunately, his sac has increased significantly. And we can see some type 2 endoleak anteriorly, even though his IMA is occluded, and some flush posteriorly to suggest there's a lumbar flow. And again, we looked at his ultrasound, and he's got significant sac progression now, bad. So what do? We thought that we should just do a diagnostic angiogram and plan to treat if something is possible. And as our previous talkers were mentioning, one of the ways to access this is through the iliolumbar. And as a vascular surgeon, I tend to do femoral access as first line. But as you can see, it's very, very difficult to get into these technical tortuous vessels. So we couldn't get there. So I cannulated this SMA. So the crux of the treatment here is to somehow get access into the sac to drop some onyx, and hopefully that would take a large part of his patent lumen, but also in the process, and that's the beauty of the onyx, is that it could take out both the outflow or the inflow vessels. And one of the route we take normally is this arc of Rion. And as you can see, we went all the way across, but I couldn't get into the IMA. The IMA was occluded. So at this stage, I thought, take my loss. He's had a long exposure to radiation, loss of contrast, so we just pulled out. Then I saw him again in June, and now the sac is even bigger. And now the ultrasound shows evidence of flow in his sac. And you can see through the power Doppler here and also color Doppler here, and I can see endoleak obvious now on duplex. Bad again. So what do? Then Medtronic tells me that Arnie Schmidt from West Germany is coming to Australia. So I thought maybe do this case with his expertise. So we put this case on again when he's around. And there's a couple of things he does which is very different from what I used to do. So the first one is that all the time arm access. And that will take out a lot of your tortuosity from your groin access. So we interrogated his right internal iliac artery, but we couldn't really see a connection into the sac. So we did his, so this is showing the lack of connection from the right side. So we did the left side, and it looked as though that there's access there through an iliolumbar into a lumbar artery. So we spent hours and hours and hours to get there, but we couldn't because of length problem. And one of the problem is that because you're coming from the arm, you need a very long, at least 125 centimeter catheter to get through this really difficult phase here so you can actually get there. So what Arnie suggested is that I do this push or slam technique. So what it is basically like the other radiologist was talking about, form a cast here, then do a push and hope that there's a forward flow. But unfortunately, there was no more forward flow, and basically I trashed his iliopsoas branches. So he needed to be admitted to hospital for a couple of days for back pain. So he's had a long operation, not sure what to do, so we pulled out. Bad again. So then he got admitted again just recently, and his sac is now even bigger. And you can see, again, this loss of contrast here anteriorly. Then we got to think cable access. And I think we overthink cable access because we always worry about puncturing normal anatomy, especially a big anatomy, but it's actually quite simple. And this has changed my practice completely. So we do a femoral access, and we just get a very, very standard catheter, sheath catheter, and we determine from the CT where the best puncture site will be. And with him, it was between L4 and L5. Then we position the catheter and be sure that we can enter in that area. And some people use IVUS, but I don't necessarily think IVUS is completely necessary. Then remove the wire, and we bud the catheter right against the wall of the IVC. Then basically, there's a couple of ways to do this, and the way we do it is to use a septal needle. So I know there's steerable sheath from Medtronic and so forth, but it won't work with your septal needle because it's pretty stiff. So no matter what it is, these needles will take precedence over any catheters. And then once we puncture through, and it's quite easy to puncture through, then we put a 014 wire and basically check our position. And you can feed your 014 wire to the top and make sure that it's restrained by the proximal seal, and you can be sure that you're in it. then you can do a run to confirm that you're in the sac. And this seems to correlate very well with the CT finding of that endoleak anteriorly. So now then what do? We balloon angioplasty with a 2 millimeter balloon to allow a 4 or 5 French glide catheter to be introduced into the sac. And over that, we follow with a microcatheter. And then we check with a diagnostic angiogram. Then basically we onyx away. This is the cast from his iliopsoas trashing that I did previously, but this seemed to correlate very well with his CT findings of an endoleak. So that's good. That's it.
So thank you very much for the case. I would like to have some comment from the panelists.
Congratulations for the case. But some of my comments, I'm still not, I'm quite reluctant to believe that this lumbar artery caused this sac expansion. Because look at the last scan you have, you show us the run of the axial scan, but if you look at the neck, I think one thing is from just the fluid loss, you have fully expand stent graft. Basically, you should have some smaller part of the ceiling zone if you still have some ceiling. I think we should have to measure the neck. Probably you don't have any ceilings or just the graft is just that right. And have some gap at the posterior aspect also, but it not explain the accumulation of the contrast at the anterior aspect of the sac. But I think if in Thailand, if I consult my IR colleagues, probably they go through the transabdominal.
Correct.
Probably
correct.
easily to the anterior aspect of the sac with ultrasound.
Correct.
That would be another access. So.
Sure. So I think this case sort of demonstrates my stubbornness, and I think one of the things that we sort of value in Australia is to sort of keep things very close to our heart and upskill ourselves basically. But I agree that one of the things that I did wrong with this gentleman is to sit too long with myself and not refer him to IR for anterior or lumbar sac puncture. The funny thing is we've done lots of diagnostic angiogram for him and we really can't detect a type 1 endoleak at all for him. And that CT finding and the cast that remained at the end of the procedure with the onyx tend to correlate quite well with that CT. So I'm hopeful. He hasn't actually come back for a follow-up yet. And I'm hopeful that we've treated him successfully, but that's something that I'll be looking out for, yeah.
Sometimes when we do the angiogram inside the sac.
Yes,
yes.
So basically we've done that all the time. Yes, correct, that's right, yes.
I mean that from the endoleak reflux into the lumen.
Yeah, and we even like inflate a balloon in each limb to sort of obstruct that so the contrast stays for a long time. But we haven't been able to detect any type 1 endoleak so far, yeah.
How do you close that cable?
Oh, nothing. You just, so once you're finished, you remove the syringe with the onyx inside and make sure that the onyx doesn't reflux back, which is a new thing that my Medtronic rep has told me. Because one of the dangers is that if you remove too quickly without the onyx set inside the aortic sac and is highly pressurized, then you will release that onyx into the IVC.
Okay.
Yeah.
Yeah, well, thank you very much. I think that's a good case for direct puncture, another route. We saw trans-lumbar, trans-abdominal. This is a cable access. And one thing though, I'm not sure that if I summarize my lesson, my experience, not my experience, sorry, my learning from this case, Dr. Masuda, correct me if I'm wrong. Can I call this endoleak, type 2 endoleak, the moya type 2 endoleak? There is one thing that is an endoleak that look like a shower head. It's diffuse. It's not direct to, we cannot tell exact lumbar branch. So if we see this kind of type 2 endoleak, don't waste your time trying to do transarterial embolization. Go direct. Either trans-abdominal, trans-lumbar, trans-cable, whatever. I think there are differences in type 2 endoleak. Those we see the branch, exact one pair, two pairs, we embolize it, may be successful. But if we see this kind of diffuse, like the case that you showed, there's a few here, a few there, diffuse kind of thing. The one that Dr. Kitisak mentioned that maybe rupture vasa vasorum, we don't know. I heard that Japanese call it moya moya endoleak. If we see this kind of thing, what do you think? We don't waste our time doing transarterial. Can we go direct? Yeah. But what do you think?
Yeah, I know. It's called moya moya.
Okay.
Yeah. So I agree with you. It's not necessary to waste time with very difficult embolization.
I mean, like the cable puncture, it took me 30 minutes.
No.
Yeah.
I mean, not doing other things. Go
Yeah.
exact what you just did.
Yeah.
You just showed. So if we see things like this, do as Dr. Cho mentioned.
So the other way to do it would be, if you don't want to use a septum needle, is to use like a hockey stick and put a Benson wire into it and then set up with a diathermy and diathermy through. And that's the other technique to do it. And then you have better control with that. Without a
So
stick needle.
trans cable is another good option to do direct puncture. Good success. So
I just have another question for my previous speaker. On his final CT, there was gas in that sac. Was he worried about that, or with Melina presentation?
That is Dr. Kao. We saw that the sac shrunk. Actually, the stent kinking too, though. Not only that gas. What do you think about that?
I didn't want to bring it up because it will prolong the discussion. But yeah, the patient is admitted because we're now entertaining the possibility of an aortoenteric fistula.
So thank you for the discussion.